My name is Emma. I am a fourth-year medical student. I go to school at the Burrell College of Osteopathic Medicine. It's in Las Cruces, New Mexico. So today we are going to be talking, if you were with me 2 weeks ago, a little bit about some more derm stuff. And this time, I think, it's truly a little less derm and a little more pediatrics and a little more virology and pathology. So it's a good mix of a lot of different things. And I decided to focus on childhood rashes specifically because they can be, common and sometimes hard to discern. So, all right, let's get started here. Let me give you the pre-poll. Let me launch this for you. So let me know, in your opinion, how much do you know about dermatology? And in the meantime, I am putting the link in the chat that has the SOAP note and all the resources that you'll need for tonight in order to complete the session. All right, so I think most of you guys are in. I'm going to end the poll there. Let me share this with you. So a lot of you guys said you know a little. Maybe that's because you went to my last dermatology session. Some of you guys said you know nothing. I think that's absolutely okay. Let's see if we can't change that for the post poll. Some of you guys said you know some. Nobody said they know a lot. So I hope to move some of you guys up there and see if we can't, teach you something and simultaneously have a little bit of fun. I like to joke around a little bit. So. And then also, sort of your role today, I'm going to want you guys to participate. I'm going to want you guys to, ask questions, to read these vignettes, and interact with me. That's what I like. First thing that I had, it wouldn't be a dermatology lesson if I didn't include something about Dr. Pimple Popper. This is actually pretty gross. This video, I think she ends up actually lancing it. I was watching part of it. I was like, oh, I'm gonna put this in, but there's so much discharge that actually comes from this. It's pretty gross. There you go. I hope nobody's eating right now. But this is a cyst, and so assumably she's going to have to take the capsule as well, because what you'll come to learn about cysts is if you don't take the capsule, it'll just fill right back up with material. All right, let's keep going before it shows us that part again. All right, so today, that should say 3. I have 3 cases for you, and then 2 slides at the end with kind of rapid fire dermatology things. As I was kind of indicating before, I would love for you guys to read the cases out loud when I ask. Fill out the SOAP note, pick one case, whichever one is easiest, or the first one, or whatever you kind of want. And fill out that SOAP note form. If this is your first time with us, welcome. And I'm going to talk about the SOAP note a little bit in a second. But just actively participate. You can put stuff in the chat. I have the chat box open, or and ask questions if you have any. Okay. All right, as I was kind of indicating, here is the SOAP note form. So when we talk about subjective, that's the S. So SOAP is SOAP. And then here's the P. Subjective, what we're talking about is HPI, so things that it's called history of present illness. It's basically a story of why the patient is presenting to the clinic or emergency room or whatever. And then the review of systems is pertinent positive and negative findings associated with the illness. So if we're talking about chest pain, we would want to, ask if they're sweating, if they had jaw pain, if they, had shortness of breath, all of these things that are pertinent positives and negatives, and we include that in our ROS. Objectives is things that we find, so things like vital signs and things like the physical exam. Assessment is our list of differential diagnoses, essentially. And then our plan is, how we are going to treat, what we assume is going on. Okay, so fairly simple. Choose one case to kind of to include the SOAP note for, and then in case you missed it, here is the SOAP note form. I just put it again in the chat. a little bit of an introduction before we kind of head into these cases. And so what we're really going to talk about here when we talk about dermatology is basically the skin, structures and really the function associated with it. That's a lot of what we talk about in medicine in general. So when we look over to the left here, what we talk about is the epidermis, the dermis, and then below it, it's called the hypodermis, which makes sense. Hypo meaning below, and dermis is the dermis. So in the epidermis and the dermis, we're going to see lots of different structures. The things that we look at are these different layers here. We have the stratum corneum, the stratum granulosum, we have sebaceous glands, we have things like lymphatics to carry the lymph fluid. And then we see things like basal cells that might sound familiar to you when we think about things like basal cell carcinoma. We have melanocytes, which is where melanoma comes from. Other than that, when we start to get down to the dermis, we see things like arterioles and venules so that we get an exchange of nutrients and oxygen. All right, and then when we get below, we see the subcutaneous fat, we see things like sweat glands, hair follicles, all these things, okay? So that's a brief kind of introduction to that. And we'll be focusing truly less on this kind of anatomy today and more about truly virology. But needless to say, let's have an introduction to these different things. And this is, what I think is the hardest part of dermatology is like classifying all these different things. So if we have a collection, basically a blister that's greater than greater than 1 centimeter, that's called a bulla. And then we see things that are flat on the skin, and they can be, hypopigmented or pigmented. We call that a macule. They're usually flat and less than 1 centimeter. Then we see if it's raised off the skin and greater than 1 centimeter, that's a nodule. And then we have similar to a macule, but greater than 1 centimeter, we call that a patch, okay? And we see other things like pustules that you guys might be familiar with. That's one of the, common ones. We see things like vesicles, plaques. We see plaques often in psoriasis. We see papules, wheals. You might know the wheal from whenever you get a PPD test to test for exposure to tuberculosis. You get the wheal under your skin of the purified protein derivative to test your body's immune response to that if it's been exposed to tuberculosis. Then we see things like scales, crust, and then, fissures, all these things that would, admittedly make you lose your appetite. But let's keep moving here. We're going to talk a little bit more about pathology in terms of childhood rashes. And there's a lot, admittedly. Some of these things you might be familiar with because they're associated with a vaccine, like measles, which is also called rubeola. So keep that in mind too. And it's caused by paramyxovirus. And what we see with that is kind of this, fever starting out. We see spots in the mouth. Those are called Koplik spots. And then we see the C's, cough, coryza, conjunctivitis. And then we might see things like scarlet fever, which is from strep throat. Okay, things like rubella, slack cheek disease, erythema infectiosum, that's from parvovirus, roseola, varicella, that's chickenpox, and hand, foot, and mouth disease. So you may see some of these tonight. That's why I'm kind of grazing over them, but there truly is a lot of things that cause rashes in childhood. So we're going to keep all of these things in mind. We're going to talk about 3 of these tonight, okay? All right, and then a quick introduction into, virology, because all of these things that we're going to talk about tonight are viruses. So when we talk about viruses, we can't not talk about the kind of life cycle. So the first thing that we see is that the virus attaches via, the proteins that are on the cell's envelope, okay? So it attaches to the host cell's envelope and gains entry here. And then what we see see is that the capsid comes out from the envelope. And we see two things happening. We see replication, we see gene expression. So we make copies of the genome that exists. That's what's happening here. And then we see protein translation where the viral RNA is formed. And then we see those two things combining, we see proteins being made, and what's happening is those are combining and assembling in order to make the actual virus, okay? And then usually the cell will bud off or, you know, have a mechanism to be released. But this is kind of in short what happens in terms of the life cycle of the virus. And then a little bit about the virus in general here. When we look at the kind of structure, usually starting from the outside in, some cells do have an envelope, some do not. When we talk about, you know, for instance, coronavirus, just coronavirus in general, not COVID-19, but there are an envelope here, and including influenza, it also has an envelope with these proteins here that help with infectivity and entry into the host cell. All right. And then inside we have the nucleic acid genome. So that can be DNA or RNA. And then we have this thing called the capsid that kind of protects that DNA and RNA. All right. And then down here, these are kind of, you know, three different ways that we see virus, kind of the genome structure itself. All right. So that's a quick kind of overlook of that. So let's jump right into the first case. And now I would love if somebody would read the first case. Don't be shy.
I can read it.
Perfect.
Okay. A 3-year-old male presents with a 3-day history of fever and general malaise.
You got it, malaise.
The mother reports that the patient has also had a rash on the palms and soles of the feet, as well as a sore throat. The patient attends daycare where several children have been ill.
Excellent. Perfect. All right. So if we look to the right here, we have a picture, you know, showing what this kid looks like. So here's the hands. We see the soles, and then we see some, you know, what could be causing this sore throat here. All right. So put into the chat or say out loud, what do you guys want to consider in terms of a differential here? I don't expect you guys to know the actual pathology. That's okay. Think what can cause a rash and a sore throat, or, you know, ulcers on the mouth, because what we're seeing here are truly ulcers. It's kind of erythematous. We see the uvula here. We see you know, these red erythematous angry vesicles on the back of the oropharynx. So what do we want to consider? Go ahead and put it into the chat. Anything that you want to consider or test for. Let's consider those things. Bacterial infection? Sure. Which one? I know which one you're probably thinking. Yeah, so scarlet fever, we can consider it. Yeah, we can consider a common cold. Viruses are the most common cause of the common cold. So yes, absolutely. Hand, foot, and mouth, good. Yeah, 2 people said hand, foot, and mouth. We certainly want to consider that. Perfect. I guess the pictures of the hands, the feet, and the mouth gave it away. But good. Anything else? Somebody said bacterial, and I think you're absolutely right. And we would want to test for that. So which bacteria do we want to test for? Strep, yeah, absolutely, perfect. And we can get a quick strep, and even if we think, you know, this is hand, foot, and mouth, or whatever we think it is, it wouldn't hurt us to get a quick swab and to rule that out, okay? Because we know that, you know, treating a bacteria is much different than treating a virus, okay? Anything else you guys want to consider in terms of differential diagnoses here? All right, so let me clear this and let's talk about this. So you guys are right, you wise people out there. This is absolutely hand, foot, and mouth. And it's caused by a virus called Coxsackie A. It's kind of fun to say, it kind of just rolls off the tongue. And this is much different than our friend Coxsackie B, or our not friend, enemy, that causes problems with the heart. And that we see this happening mostly in children who are young, so less than 10, and it can be spread multiple ways. In a child who goes to daycare and multiple people are sick, it could be, any of these, truly, oral to oral, respiratory droplets, or fecal oral. We know that children in daycare stick their hands in their pants and then touch things, and then the kids put their hands in their mouths, all of these things. I'm sure if you guys have kids, you know that as well. I don't have kids personally, but I've seen children do this. They'll touch things, put their hands in their mouth, and they're not the pillar of cleanliness, for sure. So what we see here, in the name of the actual pathology gives it away: hand, foot, and mouth. We see maculopapular lesions, kind of these raised lesions. Remember, papules are kind of raised, and they're erythematous, and they hurt. So likely, and sometimes these can pop up and not actually cause papules, but cause pain in the hands before they actually appear. So kids might say their hands hurt or their feet hurt or whatever before the lesions actually appear. And what we see is that the lesions on the hands and the feet come first. So we see them on the soles and on the palms of the hands, okay? And it lasts about 7 to 10 days. And we also see the painful oral lesions, and here they are. Here, I wanted to give you kind of a close-up of that. And what we see is these erythematous lesions on the back of the oropharynx, and that's called herpangina. All right, and here's a baby here that has it. It's kind of obviously on the palms. We can't really see this dude's feet. Maybe on the soles, but it's kind of on the face as well. And then here's those ulcerations in the mouth. All right. We can prevent this from hand washing, and the treatment, like most viruses, is supportive. Okay, so that one's fairly straightforward, and we have an image here of an enterovirus under electron microscopy. All right, any questions about this one, guys, that you have? Fairly straightforward. Hand, foot, and mouth, you won't miss it, and I know you guys won't miss it on the quiz. So if you see sore throat, oral lesions, and you see a rash on the palms of the hands and the feet, think of hand, foot, and mouth. There's fairly few things that cause a rash on the hands, and there's a mnemonic for that, but this is one of them. So you always want to keep this in mind, especially in children. All right, so good job with that one. You guys did great. Let's keep going here. All right, case 2, let's get somebody else to read this one.
I can read it.
Awesome.
A 4-year-old female presents with a 5-day history of cough and fever. The mother notes a dry cough and non-productive of sputum. She also describes stuffy nose / congestion and diffuse rash, as well as red, tired eyes. The parents assume the patient is suffering a severe cold, though wanted to get it checked out. The exam shows the following.
Awesome. Thank you very much for reading that. So what questions do we want to ask this parent? You can ask the kid too, I guess, but the question that I'm referring to is truly more for the parents. So we see oral lesions again. They look a little bit different than what we saw before, but what questions do we want to ask? Okay, allergies. Somebody said any allergies. Sure, certainly. This is an important question for pediatric patients specifically. And then also, we see this rash. We see this kind of confluent rash, okay? So what do we want to ask the parents? Any ideas? Other children? Good, yeah, that's certainly one. Yeah, when did the rash appear and is it itchy? Okay, so for Lakin, the answer to your question is it started on the face and the head and then spread. Okay, and it's not itchy. New body wash. Yeah, good job, Madison. That's absolutely one of the things that you want to ask about, especially for, you know, a rash that is in areas of the clothing, if they started any new foods, any new laundry soap, if anybody else in the house has it. Those are all great questions. And Catherine, thank you very much. You got the question. Oh, and I think someone else got it too. Yeah, Catherine got it. Oh, you said it twice. It was so important that you said it twice, which is great. And you're right. We want to ask about vaccination history. So good job, Catherine. That was the one I'm getting at. And you guys all had great questions to ask the parents. So to answer your questions, Catherine, the patient is not vaccinated. The parents said that they wanted to, you know, that they believe that their child would, you know, just use their immune system to fight anything that came along. Okay, so the child's not vaccinated. What are we thinking of now in that regard? They have oral lesions and a rash. Measles, good. Anything else? Let's get a good differential going. We always want to, it's not itchy, not itchy. It's painful, but not itchy. And you can keep asking questions if you want to know anything else. And in the meantime, while you guys are thinking of your differentials, chickenpox, sure, certainly, yes, if it's itchy especially, but this one's not necessarily itchy, but we can still include it. Things that are important are the cough, the fever, and stuffy nose and congestion, obviously the rash, and red eyes. Okay, we call this conjunctivitis. I'm not going to write all that out because that's going to give me a headache. And obviously we have no vaccinations. Scarlet fever, yes, we can. Measles, not necessarily mumps, but I do agree with the measles. People are saying scarlet fever. Are the rashes crusty? No, they're not crusty. They don't blanch. Blanch meaning when you push them, it gets white and then it turns filled with blood. Not itchy. You guys are saying scarlet fever, measles, good. Lymph nodes, yeah, they have some swollen lymph nodes, but nothing like mumps where you see like orchitis or swollen parotid or anything like that. Like they're a little bit swollen. They have a little bit of anterior cervical lymphadenopathy, but nothing more than that. How about that? So what's your guys' final guess? If you had to guess something, you know, a patient that has cough, coryza, they have conjunctivitis, they have a rash that started on the head and now is spreading, and they have lymphadenopathy, they have no vaccinations. What are we going with? What are we putting our money on? Measles. Yeah, good. Yeah, somebody said rubeola. You're fancy because that's exactly what it's called. Yeah, and it wouldn't be medicine if there wasn't 1,000 names for it. So good job, guys. You guys are all very wise. So let's talk about this. And before we talk about this, does anybody watch this show? Is anybody watching it right now? Awesome. So we have some people watching it. So hopefully, okay, multiple people are watching it. Awesome. So if you're on the 3rd season, and I won't ruin it. Well, actually, this may ruin it if you're not on the 3rd season. But no, it won't really ruin it that much. Oh, well, maybe it will. I don't know. Anyway, I'm going to say it. So in the 3rd season, these fine people run into a problem where a baby is infected with measles. Okay, so that's the issue here, and you'll find out kind of the context behind that, but that is in the show You. It's a great show. I felt the need to add it in because I literally watched this episode today, and admittedly I'm the person that turns the show on and then watches half of the episode and then falls asleep, so then I have to watch the other half the next day. I'm like the antithesis of a binge watcher. I'm like a very slow watcher. So if you haven't watched the show, it's pretty good, has a good plot, but the baby in the show got infected with measles. So I felt like for all the fans out there, all the You fans, I had to put it on there. But here we go. So this is measles. It's called rubeola, as someone had suggested, and it's caused by a paramyxovirus. All right. And what we see is symptoms that start about 10 to 12 days after exposure. So this is, anywhere from, about 7, a week to 2 weeks after the exposure. And then we see, an initial illness, cough, fever, coryza, like a stuffy nose, conjunctivitis, and we see Koplik spots. That's why the C's there. So you have the C's, cough, coryza, conjunctivitis, and those Koplik spots. Koplik spots are these guys, and how they're described is like a grain of salt on an erythematous base, so on a red base. All right. And it's a little bit different, as you kind of remember from our hand, foot, and mouth, where it's just really erythematous, kind of ulcerations on the posterior oropharynx. And then the rash that we see starts on the head and the face, and then, that was a horrible line, starts on the head and the face and then spreads. And this is, it starts about 3 to 5 days after the initial symptoms. So what we see is like, okay, this kind of looks like a cold, and then they get this confluent rash, and it's like, oh shoot, this is not a cold. And then, as you guys probably know, this is prevented from the MMR vaccine. And they're given this between 12 to 15 months, and then again at 4 to 6 years. Okay, so it's 2 in those 2 time frames. Okay, and then the way we treat this is supportive. So we manage, kind of the complications and what's going on, because if it's a virus, there's not much we can do, admittedly. And then here's a few babies down here to the down in the bottom right hand corner that have the measles rash. So these 2 kind of show them on the face. This one's kind of spreading on the bottom, but it's kind of this fine, confluent rash, and then we see it in the mouth as well. So you'll see, this one is different if we compare it to hand, foot, and mouth, because it's not on the palms and soles. Okay, it's kind of this confluent rash that is associated with an initial prodrome of symptoms, and then kind of the rash comes along. So the timing is pretty critical. So asking, when all these things started, it is pretty important. Okay. All right. So let me clear all this and let's keep going here. And I'm going to need one more person to read for us. Don't be shy.
I'll read. Okay, a 5-year-old boy presents with a sore throat and fever for 3 days. Is that what that means?
Yes. Yeah, good job. You got my shorthand.
The parents note that their other child recently had a strep throat infection, though did not have the rash of which their other son is now presenting with.
Awesome. Where are you from, Lakin?
South Carolina.
Okay, you have a strong accent. I had that. Thank you for reading. All right, so let's see here. What are the important things? Let's start there. Let me ask you that. What kind of caught your attention here in terms of the history and what's going on? Yeah, sure. So strep, fever, good. Yeah, we have a fever. A sibling had strep, perfect. Other child was strep, yeah, strep but no rash, and this one has a rash. Good. What are we seeing here? If you guys had to write this in your note in your physical exam, what would you put? Someone give me, or say it, you can say it out loud. So swollen, good, that's part of the story. What else is going on here? close to thrush. We see thrush usually on the tongue. Infection, yeah. So it is an infection, and it looks like strep. But this is purulent. It's like pus. You see the pus on the tongue, or I'm sorry, the tonsils, which can be a sign of a bacterial infection there. Thrush we would kind of see over here on the tongue, and usually in immunocompromised or babies, we see it. Okay, and now what's going on here? How would you guys describe this? Stick with what you know. So we can start with, it's hard to tell obviously because we're not feeling it if it's raised or, you know, flat or whatever, but we can say that's erythematous. We can say where it's at. So if I were to describe this, I would probably say it's an erythematous confluent rash. It does look a little bit raised, but kind of looks sandpaper-esque, so kind of raised and rough. But now, what tests do we want to order? What ideas do you guys have? You can be as broad or as conservative as you want. You guys are already giving me your differential. You're excited. What test do you want to order? So we can do a CBC. Okay, let me write all the tests that we want to order, and I'm going to give you guys the results, and then you can tell me what your differentials are. So CBC, I'll say leukocytosis. So there's a high white count, and there's a left shift. So there's immature cells. Okay. Okay, so strep. You did a rapid strep, and it's positive. And then you're sending it for culture. Culture won't come back for a few days. Okay, what else do you guys want? Anything? What do you do if the strep is positive? You can get a chest x-ray. Well, chest x-ray, we'll say it's unremarkable. Antibiotics, good. Do you know what antibiotics? So what are you giving the antibiotics for? The strep is positive. Why is there also a rash? If the patient has strep throat, why do they have a rash? And for those of you that said antibiotics, do you know which one? Yeah, penicillin based. So we usually give penicillin or amoxicillin. If they're allergic to penicillin, that poses a whole new problem. But what are we saying this patient has? Our final diagnosis, what are we going with? Sore throat, fever, we're exposed to strep. We see swollen tonsils that are purulent, lymphadenopathy, no cough, all the classic signs of strep, young, scarlet fever. Good. Great job, everybody. You guys are smart. Or do you have access to my slides? or either way. Good job. You guys are absolutely right. This is a scarlet fever. Good. And what we see here, and you know, this isn't a great representation here because strep is usually gram-positive. But we see gram-positive cocci in chains. It's group A strep. And we know that gram-positive, if you ever were with me when we talked about infectious disease, gram-positive is usually purple. I'm not sure what kind of stain was used here. But we're talking about group A strep. It's called strep pyogenes, Streptococcus pyogenes. It's transmitted through respiratory droplets. You guys have probably all had strep at one point in your life. Admittedly, I had strep like 1 billion times when I was young, and then had to have my tonsils out when I was young, and I have PTSD from that. But I haven't had strep since, so pros and cons, I guess. And when we talk about strep and when we talk about scarlet fever specifically, we think of things that are associated with strep. Fever, that was a horrible line again. Fever, sore throat, and fatigue, sure. And then when we talk about the things associated with scarlet fever, we want to think about strawberry tongue and sandpaper rash that comes. Do you guys remember strawberry tongue, something I told you that also had a strawberry tongue, kind of had a cool name, had a derm association with it? I gave it to you guys a couple weeks ago. Yeah, nice, Jack. Perfect. Yeah, good job. Kawasaki's, good. And when we talk about Kawasaki's, we talk about the conjunctivitis, the rash, the adenopathy, the strawberry tongue, and the rash on the hands. That's one of the ones that can also cause a rash on the hands. So good job. Strawberry tongue, we do see that in scarlet fever. And then we see later a rash appearing about 10 or 12 to 48 hours later. So it can show up about, it can show up, you know, about an hour, or I'm sorry, 2 days later. Sarah, if you just came on, yeah, we started an hour earlier. Because I have an arrangement to get at later, and I always go over. So this one did start a little bit early. If you missed part of it, no fear, it is recorded and you can watch it later, okay? And then things, and the reason why we fear this, and the reason why we want to treat it and catch it right away is because there's 2 big complications that come as a result of this, okay? One of which is rheumatic fever, okay? That's a big one. So here we're talking about the heart, all right? And then the other one is, that was a horrible heart. I hope nobody's heart looks like that. And the other one is post-streptococcal glomerulonephritis, okay? Say that at a party, you'll sound really cool. And then there's your kidney. So we worry about those 2 things, you know, rheumatic fever being very serious, kind of attacking the valves, post-streptococcal glomerulonephritis, despite the fact that we treat the strep infection, you can still get the, you know, the glomerulonephritis, the problems with the kidneys. To prevent it, we say hand washing, avoiding sick contacts, and then we say penicillin-based antibiotics. So that's penicillin or amoxicillin usually. So good job with that one, guys. Where will I be able to watch it? So we have a YouTube channel. At the end, I will put the link to this YouTube channel, and you can check out all of them. You can binge watch all of my videos from the start of virtual rounds until now. Awesome. So let's talk a little bit about rheumatic fever and post-streptococcal glomerulonephritis. First, let's talk about rheumatic fever. So here we're talking about our friend the heart. And what we see is just this. That was a better heart, but still kind of wonky. We talk about group A strep, kind of adhesion and invasion, okay? So we see, here's the pharyngeal epithelium, and we see that the bacterium is kind of getting access to the cell. And once it gets access, we see 2 main things happening here. Number 1, we see our friends, the B cells. The B cells are our buddies that can activate plasma cells to make antibodies, okay? So that's number 1. We see that here. The B cell receptor, that's what BCR means, recognizes, look, there's a bacterium here. This guy is not supposed to be here. So what it does is it gets activated and then correspondingly produces antibodies that are specific for that bacterium. Okay, so it recognizes part of that foreign bacterium and correspondingly makes antibodies. All right, second part. We see that the macrophage, which is literally like the trash can of the immune system, macrophages go around and, you know, eat everything. They recognize, oh, look, this guy's not supposed to be here, picks it up and presents part of an antigen to a T cell. Here's the T cell, the T cell uses its T cell receptor to recognize that antigen. And we know that T cells, there's 2 different classes. There's CD4 T cells. That's primarily what's attacked in HIV. And then we have CD8 CD8 T cells. Okay, and we know that because you know, this T cell has a MHC class 2. That's just a type of you know, receptor essentially, that this is a CD4 T cell. If it was an MHC class 1, that would be a CD8 T cell. That's a way above what you need to know, but just simple things we can kind of get in. All right. And then what we see is, you know, once those two things are activated, we have the B cells activated and we have the T cells activated, we see organ manifestations. So we see the heart and the joints, and then we could see these things like erythema nodosum. If you remember that case I gave you 2 weeks ago, where the young lady had nodules on her anterior shins, remember that was our strep patient. So remember, it can have those manifestations on the skin as well. Okay, so let me write that out for you if you don't remember. It's like a pretty big word. So erythema nodosum. That was our young lady, had the bumps on the shin, had the little brother that had a strep infection. Okay, if you guys were there 2 weeks ago. Alrighty, so now let's look at the image to the right. And what we're going to focus on here is a few things. All right, so let me get my pointer out here. Rheumatic fever and scarlet fever are two different things. Yeah, they're two different complications. So scarlet fever is a complication of strep. Rheumatic fever is a complication of strep. They're two different complications of the strep infection. Okay, great question. So what we see here is, here's our bacterial antigens. Okay, they're getting access to the kidney here. And what we see, remember, basically what's being produced from the B cells is antibodies. So we see basically B cells are producing antibodies, and what the antibodies are doing is they're going around and they're basically binding up antigen from the strep bacterium. All right, and what's happening there is these are basically going and getting deposited in the kidney tissue, and that's what's causing the glomerulonephritis. All right, and then aside from that, we're also getting things like complement activation. So that's part of the immune system. We're getting, you know, neutrophils and different white blood cells activated and coming to the site. We're getting cytokines released, which also have, you know, messengers that signal inflammation. All right, and we're getting damage and degradation to the glomerular basement membrane, so to the kidney's basement membrane, which is causing issues. Okay, and that's where we get the glomerulonephritis. We get basically inflammation of the kidney, which is a big problem, because the kidney doesn't like that. All right, any questions about this? Rheumatic fever, scarlet fever, post-streptococcal glomerulonephritis, all complications of strep. We also see problems with the joints. We also see the manifestations on the skin, the erythema nodosum, which is those subcutaneous nodules. All right. Okay, let's keep going here, because we have a few rapid fire things to do. We have, and we're probably going to end on time, which is always a miracle for me. So whenever I put these up, I want you to just, you know, shout out your guesses either in the chat or out loud if you want to unmute yourself. But we have, you know, 2 slides to do. We'll go through it. And if you guys have any questions at the end, I'll stick around for a few minutes. You can ask anything about the presentation, any topics you want to hear. We'll do the post presentation poll, and you can ask me any questions about med school, whatever. All right, here's the first one. Any ideas? Eczema, good. Great job. So this is eczema. We usually see it on the flexor surfaces of the elbows sometimes. Sometimes we see it on the back of the knees, but often it doesn't discriminate. It's itchy. You'll see it on children often, and we see that eczema can flare due to a number of things. All right, here's the next one. What do you guys think this is? It's itchy. Good job. You guys got this one. It's chickenpox. Great job. Everybody's getting it. Perfect. It's itchy, kind of all over. It's raised erythematous papules. Good job. This is chickenpox. We call this varicella. If you ever look at the vaccine, that's the virus that we're immunizing against, is varicella. What is this? I'll give you a hint. It is an infection. All right, I'll give you guys this one. This one's impetigo. It's usually because of strep or staph, group A strep or staphylococcus, okay? All right, what's this one? Nice. So somebody got it out there. Lyme disease. Perfect. We see that kind of bullseye rash. Oh, we also call it erythema multiforme. Yes, and Lyme disease is the result of a tick bite. Perfect. There's a specific type of tick that it's from. Perfect. Let's keep going. What's this, guys? I'll give you guys a hint. I had given it to you in the chart initially. And its kind of nickname gives it away. Close. That's a really good guess. Rosacea is an excellent guess. This is a tough one, admittedly. This one is slap cheek disease. It's called fit disease, and it's from parvovirus. So it has like 1,000 names, and it's called slap cheek disease because it looks exactly like that. Like you have little slap cheeks, and I always think the babies look so cute when they have that. And that's exactly what the baby looks like. It looks like it's got its little cheek slap. And this is from an infection with parvovirus B19, okay? Different parvovirus than the one in dogs, in case you're wondering. All right, what's this? You guys know this. I know you do. Good. It's warts. What virus causes warts? Anybody out there know which virus causes warts? Yeah, good job. Yeah, it's HPV. Perfect. Everybody is doing well. It is HPV. We know HPV is the virus that also can cause cervical cancer. So there is a vaccine for that. It's called the Gardasil vaccine. We give it primarily to young women. Young men get it too, to prevent HPV that is associated with dysplasia in the cervix that causes cervical cancer. So great job. All right, what is this one? Don't think too hard about this one. So say somebody close. So Jack is very close too with wheels. It is raised. So say someone is allergic to peanut butter and then they got on an airplane and they were exposed to peanuts. What might you get as a result of that specifically? Yeah, hives. Good job, Lakin. Perfect. Good job, Madison. Excellent. That's exactly what this is. Very simple, just hives, okay? Poison ivy, what we'll see, and I should have put something like that. Oftentimes you'll see it in streaks for multiple reasons, but it's a delayed sensitivity reaction. So you may be exposed on like Saturday and not get it till like Monday. So it takes a little bit of time for your immune system to kind of ramp up, but you'll see it, you know, where you were exposed, and then you'll also see it where you've scratched. So when you scratch, it kind of gets underneath your nails and then you spread it. So you'll usually see it in like a linear fashion. All right, here's the last one. This one's kind of hard, but it's on the feet. It's not hand, foot, and mouth. Don't say that. I'll give you a clue. It's an insect that causes it. Think dirty hotel rooms. Very, very close. Very close. Dust mites, also very close. Also very close. So this one's scabies. So usually, good, yeah, good, Catherine. So usually we see the little scabies babies kind of into the feet and in the webs of the fingers usually. Yeah, that's okay, Madison. It's the little scabies babies. When you see them, you'll never forget.